I want to talk to you about tinnitus retraining therapy, the way it was done clinically at University of Maryland, and then we'll talk a little bit about how we had to redesign things for the clinical trial. Tinnitus retraining therapy is a clinical protocol based on the assumption that the non-auditory systems, particularly the limbic system, which is the emotions, and the autonomic nervous system, which is the hormones, the breathing, the muscle tension, adrenaline, anxiety, panic attacks, the housekeeping kinds of things, control awareness of an annoyance to the tinnitus. Okay.
I'm sorry,
we
I
don't
can't
have
get this to work.
Okay.
Oh, let's do that.
Not psychological counseling, but it is educational counseling and sound therapy to facilitate habituation of intrusive and sometimes debilitating tinnitus. It offers a systematic method to address the issues of tinnitus, sound sensitivity or hyperacusis, and hearing loss. So there's three issues that we will address with this. When patients first came to us, when we opened the tinnitus center, as I said, we were only a tinnitus center, and they would spend 2 days with us and to do all the testing and the instructions for the sound therapy, etc. So it was a quite involved process, which had to be streamlined a lot for the clinical trials. The TRT, you should understand, is not a cure. It's not a quick fix. It's habituation based, meaning we're not trying to take the tinnitus away. We're trying to get patients to the point where it's no longer an issue in their life, where they can go for long periods of time and not think about it. And even when they notice it, it's an, oh yeah, there it is, as opposed to, oh, I don't think I can live with this for the rest of my life. The goal is for the participant to get to the point where it's no longer an issue. It addresses hyperacusis and or hearing loss if it's present. It is not a masking approach. We do not mask the tinnitus. If you mask something, the brain can't learn to ignore it. It could cover it up for a short period of time, but you don't have any long-term benefits from it, in our experience. It does not employ medication or drugs. It takes time, at least 9 months to 18 months. It does not work for everyone, but most patients are significantly improved. Tinnitus is, we're calling it a phantom auditory perception. That's the old definition. An auditory sensation not related to the perception of an external sound. It is a noise in the ear or ears or the head, frequently described as a ringing, hissing, buzzing, roaring, humming, sound of escaping steam, crickets, etc. A lot of variability in what it is. It can be unilateral, bilateral, in the head, more than one sound, fluctuating, constant, intermittent, intrusive, non-intrusive, subjective, objective, etc. So there's many, many ways to describe the tinnitus that people have. When we're looking at hyperacusis, and I will say this, we started off as a tinnitus center, but we always measured loudness discomfort levels from the first patient. What we began to see that there was a significant portion of the patients that we saw who had reduced sound sensitivity, reduced tolerance levels. And, but we also saw that as we used sound therapy, which I'll talk about a little bit later, which is an extremely small amount of sound, just a little tiny seashell sound, slightly above threshold, we started to see the loudness discomfort levels improve. And for patients who had normal loudness discomfort levels at 100, 105, 110, and they got better, it didn't matter because there was not a lot of sound up at that high level. But for the patients that we saw that had reduced sound tolerance levels up at, say, 55 decibels, 60 decibels, 70 decibels, when they improved, they were able to tolerate more and more sound comfortably. And so we began to apply that to the patients who came in with the reduced sound tolerance levels. It is an abnormally strong reaction in the auditory pathways to sounds. physical discomfort as a result of exposure to sound, whether it was could be a quiet sound, it could be a medium sound, or a loud sound, and it's very individual. The strength of the reaction is controlled by the physical characteristics of the sound, the spectrum and intensity. And again, a key word here is physical discomfort from sound. There were frequent complaints of fullness and or pressure in the ears. It was usually bilaterally reduced loudness discomfort levels or uncomfortable listening levels. It's usually bilateral, which leads us to believe that it's being controlled by something a little bit higher up in the system. Okay. Reduced sound tolerance. Since the original hyperacusis, there have been different aspects of this evolved. So hyperacusis is the physiological response with some level of physical discomfort. Misophonia, it refers to a dislike of sound, something that does not include physical discomfort. And you can think of the people that complain about sitting at the dinner table and their brother or sister or father or mother chewing and they can't stand it, and they wind up having to eat separately. So it's that's dislike of a certain sound, but not physical discomfort, irritability or emotional response. Phonophobia involves a dislike of sound, but that also includes a fear of sound, where that fear starts to set in, where you're fearful that you'll be exposed to certain sounds and you'll be uncomfortable. So there's different aspects of reduced sound tolerance, and we need to separate the different issues. The one thing that TRT does is that it gives the audiologist the ability to separate these three issues, to address all of these issues and see where the patient stands in all of these different areas in terms of tinnitus, in terms of sound sensitivity, and in terms of hearing. When a patient came to see us, as I said, they spent a couple of days with us. We had a baseline initial interview, which I'll talk about, the audiological tinnitus hyperacusis evaluation. And again, that's a way to separate and see where they stand in all of these different areas. The patients always had a medical evaluation. Depending on what their complaints were, they either saw an otolaryngologist or a neuro-otologist. We needed to rule out any medical problem or disease process. That was very important because most of the patients that came thought that they were dealing with some kind of terrible disease process. And they know they had a brain tumor, and they know this disease and that disease, whatever they've been reading, and we really wanted to give them a clean bill of health. And the physicians would refer them if they found something that needed to be addressed further. Then there was an appointment for directive counseling, and usually we spent at least 2 hours with the patients for the directive counseling, depending on the questions they had and the discussions. And this was not a lecture to them. This was an interactive kind of discussion, but we did teach them about the aspects of the tinnitus and the hearing and the sound sensitivity, which we'll talk about. Then we talk about options for sound therapy. And if they decided to use instruments, we would do an instrument fitting, and then there are ongoing follow-up appointments, and we work with the patients typically for about 18 months, 2 years, until they were at the point where this was no longer an issue and they graduated. The baseline initial TRT interview is a general questionnaire to begin to get the participant's description of his or her problem. Again, we're trying to sort out these three different areas and see where they stand. It's a clinical tool to separate the issues of tinnitus, hearing, and decreased sound tolerance. It allows classification of the participant's problem into one of 5 TRT categories, and it's a baseline for later comparison. And it really gives the patient the chance to talk about their tinnitus in more specifics, which is very beneficial for many of the patients because they've never had a chance to really describe what's going on besides saying, I hear this noise. The baseline interview, and this are just a few aspects of it. The TRT interview is much more comprehensive, but we describe the onset. Was it gradual, sudden, and when do you think it started? what does your most bothersome tinnitus, and we call that MTT, the most troublesome tinnitus, sound like? Because many patients had 2, 3, 4, 5, 6 different sounds, and we tended to go along with the most troublesome sound and address that and do the clinical protocol for that, and everything else seemed to kind of go along with that. So does any kind of sound have any impact on your tinnitus? Does it make your tinnitus louder? Does it make it softer? Is there no effect? We're looking for that patient who, when they're exposed to sound, loud sounds in their environment, the tinnitus is louder, which is an aspect of the decreased sound sensitivity. If it does get louder, how long does it stay louder? Is it minutes, hours, days? Does it usually go back to its usual level by the time they wake up the next morning? Or does the tinnitus stay louder for longer periods of time? And that's the kind of patient that has a form of decreased sound sensitivity that is a little more extreme, and we address that. What is the percentage of total awake time over the past month that you're aware of the tinnitus? The percentage of time over the past month that you're annoyed or distressed by the tinnitus. And again, there's 2 different aspects to it. There is the perception of the tinnitus and the reaction to the tinnitus. If it's strong or loud, we talk about how strong or loud it's been over the past month, the annoyance factor, the impact on life on an analog scale of 0 to 10. 10 is the worst you can imagine. So we try to do measurements of those different aspects. Do sounds cause pain or physical discomfort? If so, how long does the discomfort last? Minutes, hours, days. And again, we're getting into that sound tolerance, those sound tolerance issues, and we want to know if there's physical discomfort in the ears. The audiological tinnitus hyperacusis evaluation. We had to ensure consistent evaluations across the clinical centers in the tinnitus retraining therapy trial. So what our job was to take the tinnitus retraining therapy as it was in the clinical protocol and adapt it to the trial. And we were working with a lot of different clinicians, audiologists, physicians, and we needed to make sure that it was standardized and they were doing the same things at all the different centers. So that was a little difficult for a very individual process, which TRT is. But we had the clinicians do the testing in the following sequence: pure tone thresholds, speech recognition thresholds, tinnitus pitch match, tinnitus loudness match, loudness discomfort levels, word recognition scores, otoacoustic emissions, which is a test that looks at the robustness of some of the outer hair cells in the auditory system, and we like to do that for the counseling. And acoustic emittance tests, which are fairly loud, and we want to make sure that we look at their loudness discomfort levels before we did any loud tests, because we don't want to put patients in a lot of discomfort. Some of the patients that we saw at the clinic said that the onset of their hyperacusis or their tinnitus was an audiological test that was done previously, because some of them can be very loud, and even though they would complain and tell the audiologist, don't do this, I'm very sensitive, you know, they ran into trouble because of that. So we're trying to be very careful and not do anything that will make the patient uncomfortable. For the recommendation of treatment, the TRT initial interview delineates the subject's relative problem of tinnitus, hearing loss if it's present, and reduced sound tolerance if it's present. And again, that's, I think, one of the strengths of this protocol, where audiologists can look at these things and see where the patient stands in each of this area. The use of the interview educates the subject to understand these problems and how they differ, because it's very important in our counseling and our teaching that the patient understand what these different aspects are. The process helps the examiner determine the course of treatment depending on where their areas of problems are. The examiner recommends TRT treatment based on verbal responses to the initial baseline interview and the audiological tinnitus hyperacusis evaluation. So it's not until they see both of those test results and interview results, that they kind of know what direction they're going in. And all of this is shared with the patient. So it's very important from our point of view that the patient understand exactly what's going on. The TRT categories for patients are based on the neurophysiological model of tinnitus, which Jastropoff developed, and I'll talk about. It reflects a subject's diagnosis considering the results of the initial interview and the audiological tinnitus hyperacusis evaluation. It provides guidelines for recommended treatment, implementing counseling, and sound therapy. It depends on the dominant problem. First of all, if hyperacusis is present, if sound tolerance levels are present, the ones that call it physical discomfort, that is always treated first. So we address the hyperacusis first. For many patients, and I'll say this, hyperacusis for us was the easier thing to treat. We saw significant improvements over an 8-week period usually for the hyperacusis patients. And once the hyperacusis was improved and patients could function in a busy, noisy world, for a lot of those patients, the tinnitus became less of an issue. So we addressed that. Patients may change category during treatment. For example, hyperacusis is no longer an issue, and hearing loss, if it's present, or tinnitus becomes a major concern or non-concern. So once we address the hyperacusis, then we can go from there. And I will say this, many of the patients that we saw had fairly normal hearing, and I'll talk a little bit about that a little bit later. And so they used sound therapy, but after that they did not need amplification. But if somebody has hearing loss and hyperacusis, you have to address the hyperacusis first so that they can then go into appropriate hearing aids, because a lot of times patients with hyperacusis are fit with hearing aids, and they go out into the world and everything's amplified. It's just what they don't need. So we have to see where they stand with hyperacusis first. The categories for TRT, and this is not related to any other tinnitus programs necessarily, but category 0 is tinnitus is a minimal or very recent problem, and they respond very well to a little bit of information. Category 1, tinnitus is present with a high impact on life with no hyperacusis or subjective hearing loss. Category 2, tinnitus is present with high impact on life with the presence of significant hearing loss. So this is the patient with tinnitus and hearing loss. Category 3, you start to see the hyperacusis. Hyperacusis is present with high impact on life. The presence of tinnitus and or hearing loss is irrelevant in the beginning because the hyperacusis is treated first, and then you can move on to the other issues. Category 4, hyperacusis is present with prolonged sound-induced exacerbation. It's a little more extreme form of sound sensitivity. The presence of tinnitus and or hearing loss, again, is irrelevant. So that's just a more extreme form of the sound sensitivity. For the purposes of the tinnitus retraining therapy trial that Bobby talked about, we saw category 1 patients, tinnitus with no hyperacusis or significant hearing loss. Category 3, which is hyperacusis, no prolonged effect of noise. Tinnitus is present or absent, and hearing loss is irrelevant, again, because we address any kind of sound sensitivity. And by the way, for this trial, we really didn't know how much hyperacusis would show up, because you think from all of this sound explosions and things like that, there may be a lot of it, but there was not a whole lot of hyperacusis that showed up with these patients. Category 4 patients we also saw, and that's that more extreme form of hyperacusis, the prolonged effect. So that was the testing that we did. For directive counseling, it again is about 2 hours. It's a very interactive discussion where we try to educate the patient about a lot of things, which I'll talk about. One of the 2 essential core components in TRT and crucial to the success of the program. For some patients, just the directive counseling is enough. Once they understand what it is they're dealing with and where they can go with this, they're fine. And it's like medical problems that many of us have, and we just can't get a handle on it. We can't find a doctor that'll sit down with us and really explain it in an understandable way so that it diffuses all those fears and concerns that we have. So the directive counseling is educating a patient. The overall goal is to educate the participant about what the tinnitus is and what it is not. So there is a reappraisal of the condition. They really can understand what this is and what it isn't. Directive counseling attempts to neutralize the negative emotional associations with the tinnitus and lay the groundwork for habituation of the reaction to the tinnitus. So it really starts the whole process. And again, as I said, for some patients, that's really enough. Participants are seen individually, although family members may be present if the patient wishes. Usually takes about 2 hours, depending on the questions they ask and their concerns. Directive counseling is educational, not psychological or psychiatric counseling. Directive counseling concepts are reinforced throughout the follow-up appointments. So if they become our patients and they come back for follow-up and we continue to do testing, a lot of what we talk about in the directive counseling is reinforced because it's a lot of information. And although we give them handouts and things like that, we need to reinforce areas that continue to be a concern or explain why they don't understand. The directive counseling outline. We review the results of the audiological tinnitus hyperacusis evaluation. We have an audiogram where we can show them where they stand in terms of those test results, including the hearing, including the loudness discomfort levels. We talk about the anatomy and physiology of the auditory system, how the brain handles the auditory input, how does this relate to the participant's input, tinnitus, why do I have this? Neurophysiological model of tinnitus, we talk a little bit about that, the goals of our treatment, and what are our options. It's very important for patients to understand what are our goals, where do we want you to be when you graduate from this program. And the habituation concept is very important. I'll talk a little bit more about that. First of all, with the overview of the anatomy and physiology, and I won't go into a lot of detail now, we talk about the whole middle ear, outer ear, inner ear, the cochlear structure, which has the hair cells, outer hair cells, inner hair cells. And the main message here is that we don't hear at the ear, we hear at the brain. And we're learning so much more about the brain and the importance of the brain in terms of all of our physical activities. The inner hair cells, and we have inner hair cells and outer hair cells, are responsible for about 95% of our hearing. They are transducers which convert vibrations into nerve impulses. Most of the attached nerve fibers are what we call afferent, going to the brain, taking the information to the brain. Okay. We have a whole other set of nerve fibers that are coming back from the brain. After the brain gets the information and decides what it wants to do about it, it sends information back down to the outer hair cells, and it can control what we call the gain or the sensitivity of the hearing issues. So we have a lot of stuff going and coming from the brain, from the auditory system. This is a diagram of the whole system. This is the cortex, where we know what's happening around us for everything. But we have all of these nerve fibers, the afferent coming up to the brain with, as you can see, a lot of crossing over, as Rich talked about before, that things can pop from one side to the other, and then going up to the cortex, we're aware of it. There are at least 5 lower levels of the brain in the subcortical, subconscious areas that act as a monitor or a filter. We can't possibly pay attention to everything going on around us. So we have to have some mechanism to filter out the junk or enhance the stuff that's different, dangerous, new, important, and send that information up to the brain and alert the brain. So this is kind of the gateway in here in these subcortical areas of the brain. 3 minutes, okay, just cut me off. Again, how does the brain handle the input from the auditory system? And these are the subcortical areas of the brain. and it filters out the junk, enhances everything that is different, dangerous, new, or important, and that can be good important or bad important. So there's a lot of evaluation going on constantly. How does the brain handle the input from the auditory system? The auditory signals are recognized as neural patterns, the information coming from the hair cells and along the nerves. Classification of signal importance is programmed by our experience, by our personality, by our learning, by our genetics, and will vary from one person to another. In other words, everybody's different in terms of how these areas label the information coming from the auditory system. And not only the auditory system, but our nose and our toes and our eyes and everything. So it's constantly evaluating it, and that is controlled by different personalities, different experience, different genetics. When we talk about genetics, there was a question before about it. A lot of people who had lived with a parent, say that, or a grandparent that suffered from tinnitus, and their whole life as a child was working around, you know, grandpop who had these noises and problems with the ears, and they get into adulthood, and all of a sudden they hear a little sound, and they think, oh my gosh, is this what grandpop had? So it's not genetic, but it's influenced by genetics. We also get a lot of perfectionists and people who are type A personalities. They not only are that way cognitively, but they're wired that way. They can't be any other way if they're a perfectionist. So they like their systems to be working well, and what they consider well, and the way it was working before. So you get a lot of that, of those issues too. The ways that the brain works in terms of, it works in a couple different ways when it's evaluating things. Selective perception. We can't pay attention to everything going on around us. The subconscious blocks the neutral information and enhances the information that's different, dangerous, new, or important. It's like you put your clothing on and you feel your clothing, but after a few minutes you don't feel it anymore because your brain has, the subconscious has said, it's something that's not dangerous, it's neutral, I don't have to pay attention to it. If you think about it, you can feel it. That's habituation. That's where we want to get the tinnitus. The tape recorder, if we took a tape of what was going on in this room and you think it's fairly quiet and listen to it, you can see that there's lots of sounds in here that your brain has not been paying attention to. Sensory contrast. When the subcortical areas look at a signal, it views it as it relates to its background. The perception of signal is based not only on its absolute physical intensity, but its relative strength compared to the surrounding signals. So a birthday candle in a dark room will be much more noticeable than a candle in a sunny window. The same issue applies to tinnitus. The perception is stronger and louder when you're in quiet. I'm not going to talk about this, but they put people in an anechoic chamber and 94% heard some kind of sound. So absolutely everybody has a busy, noisy auditory system, okay? And we can't make a conscious decision about what we want to pay attention to, but the subcortical areas can override everything and send that information up to the brain. You're trying to read a book or write a report, and your subconscious says, don't forget to go to the bank, don't forget to go to the post office. It has the ability to override everything else, and it can control everything. Is that it, time-wise? Okay. Prioritization. It doesn't depend on the size of the signal, but rather the perceived meaning of the signal, right or wrong, as to whether the subconscious alerts us. So you're lying in bed, and you hear a little crack in the floor, and you think, oh my gosh, somebody's in the house. And you know, it can waken you up just as you're falling asleep. But you can sleep through a big booming thunderstorm and it doesn't bother you. So it's not the size of the signal, but the relative importance to the brain. And those subcortical areas are the areas that are controlling everything. The brain is very plastic. It's under constant reconstruction. And all of this information can be changed. You can be retrained to filter out this tinnitus. And I'm not going to talk about this because we don't have a whole lot of time, but this is Dr. Jastreboff's model. But the main goal of habituation is habituation. The main goal of TRT is habituation of the reaction, getting you to the point where you don't notice it for the most part, and even if you do, it's an, oh yeah, there it is. The other half of it is habituation of the perception of the signal. We're not trying to make the signal go away. The counseling for hyperacusis differs a little bit. We talk a lot about the gain of the auditory system and how we can try to reverse that. Sound therapy, I'll just say, is sound therapy. We need sound in some form. There's nothing magic in the sound generators that we use. It's a very small amount of sound, just slightly above a hearing threshold, and it's a steady, stable sound that moves with the patient. That is very, very tiny. But there's nothing magic in the sound generators. It's the correct use of environmental sound and sound in some form. So that's why some of the differences that we see with a partial TRT in the clinical trial, I'm not so surprised, because if they're using environmental sound, they can use that very effectively towards the goal of habituation. And I'll have to leave the rest for another day.